Welcome back to Office Hours with Dr. Ellen Derrick. I'm triple board certified in general and vascular surgery, also obesity medicine. And one of the questions I get asked all the time, oh my God, GLP-1, which one is right for me? Are they all the same? What's the difference between Wegovy and Mounjaro? How do I decide? How do I dose? What are the side effects? So many exciting things. So today we're going to just crack that just a little bit. So, GLP-1 is a peptide that is naturally created in the body. One of its jobs is to reduce your appetite and also reduce your inflammation. And it does that by working with your macrophages and down regulating some of their inflammatory cascade. And that's important. And we can talk about the implication of that with atherosclerosis and also with lipedema. And there is some terrific literature that's already been published on this. But it will give a person the brain signal that they're full and they can stop eating. I like to think of GLP-1 as neurosurgery in a shot because it is, in fact, working on your brain and changing the chemistry in your brain. And that then dictates the chemistry in your body. It's very cool. Oh yeah. Okay, so there's four names, and I'm going to walk you through it. This is the Tylenol powwow. So there's Wegovy, there is Ozempic. Those are semaglutide. Wegovy, Ozempic, semaglutide. There are two others, Mounjaro and Zepbound, and that's tirzepatide. And there's a difference between the popular name or the branded name and the chemical name. And this is the Tylenol story. A physician may say to you, "Go take some acetaminophen," and the patient says, "Oh my goodness, what on earth is acetaminophen?" But if they look on the bottle of Tylenol, it'll say Tylenol, and in parentheses, it'll say acetaminophen. Acetaminophen is the chemical medication, and Tylenol is the brand. And then now you'll see generic acetaminophen or generic Tylenol. To make this easy, when I speak with patients, I say we have semaglutide and we have tirzepatide. Semaglutide is GLP-1, tirzepatide has GLP-1 and GIP. So GIP is an additional peptide. It is also naturally made in the body, but it appears to have a greater impact on abnormal inflammatory cascades by working on the macrophages, working also directly potentially on the adipocytes. I talked in an earlier episode about the browning of white fat, but GIP may play a role in activating beige fat, and it might help abnormal fat that we see, for example, in lipedema. They're abnormal white fat. There may be something to the GIP component in tirzepatide that helps that abnormal white fat have more normal fat process and be able to have some of the conversion of beige fat within the white fat, which we call the browning of fat. So the browning of the fat may be improved by GIP. Oh, wow. Okay, so they were originally developed for weight loss. The study of obesity is a very exciting one. And when I started medical school, I went to medical school in San Antonio. And at the time, San Antonio was the third most obese city in the country. So I was really privileged to be around some of the country's really groundbreaking researchers looking at obesity because their hypothesis was there's something about a certain level of extra fat cells that generates almost a new system in the body. And that really was the beginning of obesity research. And GLP-1s came out of that research, learning about leptin and different neurotransmitters in the brain and how obesity maybe was even a neurologic disorder. And by that, it was abnormal brain chemistry. That's where the defect was. So they were asking those questions. I was learning a lot as a medical student. I then start to become a general surgeon, and we do a lot of gastric bypass surgery because at that time we didn't have a medication or a nutrition pathway or an exercise pathway. Once obesity impacted a patient's metabolism and they developed high blood pressure and they developed diabetes and they developed sleep apnea and they developed liver failure from abnormal fat storage, the only thing that we had was a mechanical approach, and that was gastric bypass. So we did a lot of gastric bypass for a long time, and that was very successful successful in helping patients manage the disease of obesity and also some of the secondary diseases that come with obesity. So then GLP-1s come. Now GLP-1s exist. That's where it's really cool because GLP-1s are like brain surgery. So going back to my professors when I was a medical student talking about that maybe obesity is really a brain problem, a neurologic problem. Now GLP-1s, we know they work on the brain to change the different signaling. They reverse a lot of the metabolic processes that happen. They reverse the additional storage that happens by telling the body that they're satiated and the body doesn't have to eat. Then that also downregulates the hunger signal. And so what's remarkable is that gastric bypass is almost going away as a surgery. They are doing so few surgeries. And in fact, they've looked at GLP-1s and it is almost a replacement for gastric bypass surgery, which is so exciting because there are a lot of complications that come with gastric bypass surgery. And some of the gastric bypass surgery cannot easily be reversed once it's done. So GLP-1s have changed the game. So GLP-1s have amazing applications. So GLP-1s have been studied for cardiovascular disease. And if you read the SELECT trial, but it reduces stroke, heart attack, and death because of its impact on inflammation. As a vascular surgeon, this is very exciting. We might find that adding GLP-1 to a vascular surgery patient, if you're treating their hypertension, treating their diabetes, you're having them stop smoking, you're having them exercise, we might find that adding GLP-1 for these patients reduces amputation rates, reduces bypass rates, reduces stroke rates, reduces heart surgery rates, and that's wonderful. The surgeon in me is a little sad because those surgeries are technically wonderful to perform, but as also a human being who's a patient, it's terrific to know there could be a shot or a pill that saves me from an operation where I could die, so that is terrific. We are studying GLP-1s for cancer prevention, for dementia prevention. We are studying GLP-1s for sensitization for chemotherapy because we're observing in some populations over in Europe that patients that get chemotherapy that take a GLP-1 respond better. The Lipedema Foundation is working on connecting patients to studies in Europe, looking at GLP-1 specifically, the use with lipedema. So we will learn. I think probably everybody with lipedema should be on a GLP-1. Anybody potentially is a candidate for GLP-1. Science is working to catch up to tell us who and how much, and should it be semaglutide or should it be tirzepatide or should it be a newer, different formulation that are in the works coming soon in 2027. So it's a very exciting time to be board certified in obesity medicine. And to the question of who is not a candidate for GLP-1, so probably the three black box warnings are personal history of medullary thyroid cancer, gastroparesis, and probably a hard or a medium hard on and gallstone pancreatitis. And that has to do with the slowing of the intestine is a side effect that's often dose related, but we certainly wouldn't want to kickstart some pancreatitis on a patient. Sure. Okay, so negative side effects for GLP-1. Yes, definitely. Some of the negative side effects, they're often related to dose. And nausea is one. Gastric reflux is one that can be very difficult for people to manage. Constipation is one. Hair loss, 3 to 5%. It's not permanent and will come back. People talk about Ozempic face. So I am 51 now. I had my birthday last week on July 4th. And what I can tell you about the aging face is that we lose bone in our face. Yes, not just in your back. You also lose it in your face. And that starts something that I affectionately call the mudslide when people's faces start to slide. Sadly, as this is happening, if patients lose facial fat at the same time, it can really emphasize the aging face. That is what a lot of Ozempic face is. It's not permanent and it can be treated for that, but a lot of patients find that very discouraging. The two other components that are maybe negatives for GLP-1, it can impact the absorption of your birth control. So you can get pregnant on the same dose of birth control. So you have to think about that. You got to talk about it. I find it so interesting, but whenever patients talk about depression, cholesterol, or weight loss, there's this thinking that they should be able to control that or treat it without a medication. And there's maybe be a shame or a stigma in taking medication for depression or anxiety, or taking a medication for cholesterol, or even taking a wonderful medication like GLP-1 for metabolism management. So there can be a shame with that. And I always try to explore that with patients, because if you need thyroid replacement because your thyroid doesn't work, patients don't say, shucks, my thyroid should work and I need a plan to get off my thyroid medication. I mean, no one says that. Everyone says, wow, I'm so glad there's Synthroid and I want to get my levels right, but I'm so thankful there's thyroid replacement. GLP-1 therapy is potentially for life, depending on why you're on it. And studies show that if you're on it for weight loss, if you stop it in a year, you've almost regained all your weight. And I think for inflammatory disorders like cardiovascular disease or lipedema that are not curable, you'll need to think about being on a GLP-1 at some dosage, potentially forever. So there's that little shame piece that people carry. And I think maybe the downside right now is the cost, because it does seem like the folks that need it, that benefit from it, when they stop the medication, their disease progresses. And so it is a long-term cost. But if you look at healthcare economics and you price out the cost of taking a medication monthly for life versus the cost of a life-saving operation and prolonged hospitalization, I think you would see that it's certainly the small incremental cost monthly is going to still equal better cost effectiveness long-term for healthcare economics. What can it not do for lipedema? Okay, so GLP-1, what can you expect when you take it for lipedema? You can expect weight loss on the scale. You will be losing some of the fluid because it will help correct the abnormal inflammation pathway in your body. Your body will be more able to give up the fluid that is trapped in the lower extremities. So your lower extremities will get softer. You will lose diameter. You will also lose fat that's been stored in your body. And many folks over time have fat that is stored. So you'll also have some loss in your adipocyte in other areas that are not lipedema. And that can be desirous for some, maybe not for everyone, but for some. Your lipedema tenderness will get better. Patients are very clear. They tell me exactly the dose that they need of their GLP-1 and the frequency. I mean, it's really impressive. Patients know for sure. The lipedema tissue itself is still going to be there. It is not going to reduce your lipedema tissue. It may reduce the appearance of the shape of your lipedema. It may reduce that, but you will always have lipedema. I think of GLP-1s as sort of an in-between or a part of surgical management. Starting a GLP-1 with lipedema is a great way to ask yourself, wow, is this controlling my pain and is this enough? If this is enough for now, maybe I don't go straight forward to lipedema reduction surgery. I have time for America to get its act together on insurance coverage, for example, because really the only true way to reduce the burden of lipedema tissue and lipedema diseased fat is to have lipedema reduction surgery. Okay, what do I want everyone to know who's on a GLP-1? One of the most common worries people have is, will I lose all my muscle? And yes, if you quit working out, you will lose all of your muscle. If you reduce your caloric intake, in the beginning, your body can handle that and you have storage of nutrients in your body and those can be utilized. But after you go through that storage, your body is going to go to muscle and it's going to break it down to use it, just like in the way olden days, if you're doing a fad diet. I mean, I've heard so many like the lemon diet. So I'm 51. There's been a lot of fad diets in my lifetime, but all of those work on restriction. And if you over restrict and undernourish your body, yes, your muscles will break down. When you start a GLP-1, it is normal to have a reduction in your energy because you are resetting the energy balance of intake and expenditure. When you're in that phase, you may not have the energy to exercise. But the studies show once you get through that phase, if you're in an exercise routine program with weightlifting before you start your GLP-1, you go back to that routine once you've recalibrated your balance on GLP-1, you will still have terrific muscle mass and bone density, and your hair will recover. So I think the important piece is those are not end of the road has to be, but when you're being managed correctly, the physician will help you get back on track so that those potential bumps can just be little speed bumps, but not forever outcomes. Y'all, Thank you so much for taking time to join me on another episode of Office Hours with Dr. Ellen Derrick. And I really hope this episode on GLP-1s and lipedema can help you put these two together. And even if you don't have lipedema and you're just a human being, I hope this episode was really informative for GLP-1s. Thank you.